Welcome to Collaborative Intensive Bridging Services, otherwise known as CIBS. CIBS was a service developed particularly to help at-risk youth and their families. Now, these children were typically the type of kids who would go to long-term residential treatment centers. And back in 2009, Dakota County was experiencing just that situation. Many of their children were going into residential treatment centers and were staying there longer than expected, or they were going in for multiple episodes of treatment. And Dakota County asked the question, how can we do this differently? The result was the formulation of the CIBS model. Now, CIBS is pairing intensive in-home therapy along with a short-term residential program and merging these two together to provide a brief integrated services for youth and families, really trying to minimize or stop problem behaviors that these youth are exhibiting. There's actually 3 phases to the CIBS program. In the first phase, an intensive in-home therapist goes to the family's home and begins a 2 to 3 week assessment process with the family. In this situation, the therapist is gathering information from both the family, the child, other systems who might be involved with the family, including people like referral sources. It could perhaps be school personnel. Really, wherever the child and family are interacting, we want to know information about that will help us better understand the situation with them. During that 2 to 3 week time frame then, the therapist is formulating their hypothesis or their best guess as to what are some of the things that are affecting some of the current family functioning. One of the most significant shifts you'll see in this type of work is that although we are working intensely with the child, it is really the family system that is the focus of treatment. So by the end of that first phase of treatment, we want to have the RTC answer some pretty specific questions about what's going on currently for the child. The therapist that started in phase 1 will continue during this 30-day time frame at the RTC. What also occurs during this time frame is that the in-home therapist staff works closely with the RTC staff. Oftentimes, RTC staff may be providing co-therapy during this time frame. We'll be providing frequent contact with the family regarding their child's progress there. There's usually 3 staffings that occur during that time frame at the RTC, so the family is well informed about the progress being made there. One of the things to note about this experience is that children within a 30-day time frame typically are not fixed. They are, though, exposed to certain skills and are expected to practice those both during the regular day at the RTC as well as during home visits. And home visits occur on a frequent basis during that 30-day time frame because we want the kids and families practicing the skills necessary to help them be more successful back in the home setting. After the 30-day placement, the child goes back into their home. And then there's, in phase 3 then, it's intensive in-home therapy follow-up, which occurs typically 6 to 7 months following that second phase of treatment. During this time, the same in-home therapist that started with the family continues the work with the family to continue to solidify the gains that were made during the earlier phases, as well as the ongoing work that is necessary to cement the changes that have occurred in a more permanent way with the family. There are 4 partners that are part of this process within CIBS. The first one, most obviously, is the child and the family. The second partner is the Children's Mental Health Case Manager. Third partner is the intensive in-home therapist, and while the fourth is the residential treatment center or RTC that is involved with the family. What's different from this service compared to services as usual is that all 4 of those entities are expected to be collaborating and working closely with one another to help benefit the child and the family overall. As part of that, there's a high level of communication and collaboration that occurs between each of those 4 systems. One can expect that there's going to be at least weekly contact between, for instance, the therapist and the case manager, often more frequent contact between the therapist and the RTC staff while in placement, the child is in placement, and typically the therapist is having frequent multiple contacts a week with the family in some sort of capacity. That could be individual, it could be family, it could be couples work, whatever is being worked on that is felt to offer the most benefit to the family in changing problematic behaviors. Well, thank you for joining us for this segment of Collaborative Intensive Bridging Services, the model. And within this discussion, we're going to be talking particularly about the Residential Treatment Center, the RTC component of treatment. And we have with us today John Stumbris, who is the Director of St. Joe's Children's Programs. And John will be sharing with us some of his thoughts about doing this type of model, what kind of things the RTC staff need to be aware of in doing this, as well as how it's different from services as usual. So welcome, John. So John, talk a little bit about, as this model is developed, how does this differ from some of just services as usual?
Well, we can talk a little bit about how some of it's the same, because I think that's important too. Sure. But so let me talk a little bit about how it's the same and then how it's different. Staff from a youth counselor perspective, and actually I think from a therapist perspective too, that you still have to have a relationship with somebody to do good work. And so the sort of basic work of getting to know who the child is and why are they here and what can I do to be helpful to you and how can I help you feel safe in this kind of setting, and that basic relationship building to sort of establish that trust is really no different with kids coming in under CIBS as it is with kids who might stay with us for a longer period of time. There's certainly a little bit more collapsed because the time frame is shorter, but the truth is I think youth counselors are used to this sort of high turnover and kids coming in and out, and they're really quite adept at establishing those relationships. And I think just need to trust that's still important, and an expectation for all to do good work. The parts that are a little bit different is when we accept a child in for residential, we take a fair amount of responsibility to try to sort of work with that and figure out what are the issues, what can we be helpful, work that through with somebody, have them demonstrate that for a period of time before they leave, and then children are discharged. And so that I call that more traditional residential, where kids might stay with us more like 5 or 6 months, and certainly sometimes kids stay longer because of external factors mostly. So with the CIBS model, the sort of the later part of that treatment is really being taken care of by the outpatient FACS therapist in terms of, and so our role is what can we learn, what kinds of strategies can we try out, and what can we learn about that, what can we teach the child in a pretty short time frame about how do they understand what's happening, and how do they understand therapeutic language in many ways, and once they've been able to get that understanding, in many ways that's our job. We've been able to be successful. We don't necessarily have to see that demonstrated out for a month or 2 months or 3 months, because that part of the work is really the responsibility of the FACS, the outpatient therapist once a child leaves.
As CIBS therapists, your work with the residential treatment centers, the RTC, is fairly unique too. So maybe talk a little bit about what RTC staff can expect as part of your involvement with them.
What RTC staff can expect is a fairly different model than they're used to. It's not the traditional long-term treatment model. It's very brief. And so I think RTCs, in general, they need to expect that I don't know if I would even say expect, but hopefully allow us to guide them in what we need them to focus on during the very brief period of time that they have with our client child, and make a little bit of a departure and think outside the box from what they might typically do, and it might be a challenge at times, because we might be asking them to do things that are quite a bit different than what their normal routine is. They have units that have multiple children on them, and maybe only 1 or 2 of those are children that are in our program. The rest are in the more standard long-term model. So it's sort of asking them to rise to that challenge, to let us teach them, educate them about the model, and get them involved with it in a successful way.
It's hard for you know, our residential staff, because they take a great deal of pride in what they do. And they want to make sure that it's effective, because nobody likes to do work and then sort of think, oh gosh, this is going to revert back again. In you know, we've seen some progress here, and they'll go home, and within 2 weeks or 4 weeks, it's going to look just like it was before. And so it takes a little, it's more of a leap of faith that indeed that work's going to be ongoing when they leave, and the pieces that they've done while the child is there are going to carry on.
So Mark, we're talking a bit about the role of the RTC, Residential Treatment Center, in this process. And could you talk a little more about the role that they play, in particular how the RTC and case manager interface?
This has been a pretty significant change for facilities. Their model historically has been that they work with youth 6 to 9 months. So to have this short a time with the youth, we really needed them to start in a different place. And so when we bring youth to facilities, assessment work's been done, and there's a pretty focused goal for the intervention. So more typically, a therapist at a facility would be in the role of doing assessment and developing a treatment plan and the goals. Well, in CIBS, we're really bringing the assessment to the facility, and we're bringing the goal to the facility. So we've needed to be encouraging of the therapeutic staff at the facility about what their critical role is. You know, we didn't want them to feel displaced, that they didn't have their typical role, but rather they're so critical to being focused on developing the skill in the youth that's going to allow them to be back in their family home in a safe way. And they need to help support the other staff, the staff in the milieu on each unit, that they're making the best possible opportunity to reinforce this new skill and to apply this skill in their living there, and reinforce it when they're visiting at home and they're using the skills that we need the youth to use to be a safe family member, that they're doing that as well. And so it's a critical role, but it's a little bit different role than what they're used to.
Right. Maybe just backing up a bit, within the CIBS model, typically there's an in-home therapist working with a family 2 to 4 weeks before they even come to the RTC. Right. And so one of the differences I see is that the in-home therapist is coming with their assessment of the family's functioning, with both between what the therapist has done as well as the case manager who's involved with the family are coming with specific questions to the RTC saying, can you answer this for us? You know, does this child possess this skill, or can he exhibit it within the RTC setting? And so we talked a little bit about kind of compressed timelines, or I know you mentioned that a bit, and that's, I think, one of the shifts too that the RTC staff, I'm sure, go through, is that suddenly you're coming with a kid with specific questions that you're wanting to ask, rather than maybe a more general approach. Yeah, could you talk a little bit about that?
I can, and it's a specific challenge, I think, for staff in our residential setting, because the goals are they're more specific,
Right.
and I'll put it that way. And so, but when a child comes into a setting like ours, and they're being exposed to all sorts of different kinds of things, and different kids and different staff, and in a new school setting, it's often you'll see all sorts of other things that will sort of develop, or other issues that people will go, well, gosh, what about this? And well, I'm experiencing that with this child, or this child is having this kind of difficulty with these kinds of peers. It's easy and actually almost difficult for our staff not to sort of follow those particular trails when they see them, because indeed that's part of their job, is sort of take a holistic approach to what's happening with a child, sort of put those pieces together. And so it's more of a challenge for us, because what we're asking everybody is to say, well, we've got 30 days, and we've got these 2 or 3 goals we really want to be specific to focus on while we're here. And we don't want to get caught up really heading off into all these different other paths. Good to notice, but your primary task is to sort of keep in your head, so that they're here, we're doing this and this and this, and what can I do to tailor my interventions and my communications and interactions with that child and family to focus on those 2 or 3 things.
Right.
I think, kind of going off what you were saying, Luke, when we've done a lot of that background work, and as soon as we get to the RTC, we're running. I think in some of the cases that I've worked in that have been the most successful is when I could consult with RTC staff and say, these are the specific things I'm working for or looking for. Can unit staff be extra aware of these 2-3 things? And when they can come to a staffing and report, okay, Sarah, these are the 3 pieces that you were looking for. Here's what I know as somebody that's working with this child one-on-one regularly on the unit. This is what I'm seeing. And I think that that's really been really incredibly beneficial for informing us that don't see the child 8 hours a day, 5 days a week.
Right, we're never gonna see the child that often.
Right.
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 What's most beneficial to us from the RTC staff is to hear about the function of behaviors that they're seeing and what they might be starting to observe or theorize
Right.
around that, rather than just sort of a tallying of behaviors or
Right.
incidents or so forth.
Right. What is it connected to?
Yeah, yeah,
If this is the behavior, what's before it?
right.
Oh, you're seeing phone calls are before that every time? Good information to know that I would never know otherwise.
Yep.